So there's your stuff, and here's your speaker. I've memorized the 15-minute introduction to this visiting fireman, and tried to learn everything I could about what he's going to talk about so I could give you the details about that. So let me see if I can do that. Don's going to talk to us today about information.
All right.
I think you do know Don. He's the vice chair for research. He's been here for 5 years. He's in the middle of being successful and doing what he's doing. One of the things that he happens to be good at, it's not necessarily a core feature of your ordinary shrink-wrap generic director of research, but he happens to really be good at information technology, information systems. And he's interested in how we regard and use complex exchange and shape information so that it's useful for us as community health interests, stakeholders, and otherwise. And he's going to talk about some of those issues today. I'm going to leave it to you, Don, to talk about what you're going to talk about because you're going to talk about it. So you can just come on up and talk about it.
All right. Thanks, Frank. So this is going to be a little bit of a different talk than we sometimes do in this forum, in that I'm not going to talk about things that we've done or are doing. This is going to be more of a vision talk. So I don't know if that scares anybody, but I'm trying to put out a vision for how we can address this issue of information that we have in the healthcare sector, information that's out in community service organizations, all of which I'm going to make the case is important for us to actually do the job of promoting health within communities. Okay? So that's the focus here. So the words on the screen here are chosen pretty intentionally. We've got the medical side, we've got the community side, and this is about caring for individuals. How can we best promote the care of individuals, not necessarily the health care of individuals? Okay? So, and those of us that are kind of working on this, we're playing around with this hashtag #ShareCareInfo. You can use it if you like. All right. Let me see if I can advance this thing. Oops, there we go. There we go. So I want to thank a few people here. So some of you got a chance to meet these guys at NABCRAG. A little more than a year ago, I made a trip over to Newcastle, not on the western slope, Newcastle in the UK, and I'd already met Nick Booth, the guy on the left. Nick is a family doc who's been working on health information stuff in the UK for a long, long time. He was kind of instrumental in the work that happened about 15 to 20 years ago to try to link up GP practices and the National Health Services up to something called the spine. And the notion was that all those practices would be able to share information, all of that. I can't recall the exact number of the millions of pounds that they sunk into that. Pretty much a failure. So Nick has been through some wars when it comes to linking up health information. Mike Martin, the guy on the left, or on the right, on your right, is he's a very interesting guy. Started his education with the Jesuits. Sort of thought he was headed for the priesthood. Crossed over into engineering. Spent the first part of his career in the telecommunications industry in the UK and in Europe more broadly, and then came over to the healthcare side. So both Nick and Mike got together to do something called the Durham-Darlington Health Record, which was kind of the first pilot of what I'm going to be talking about. That was in the early 2000s. And this is a picture of them in the San Luis Valley. So we were traveling between Durango and Denver. And the other guy who's been a part of this is Mike Klinkman. Mike's an old colleague of mine from University of Michigan, family doc. Mike and I have collaborated on a lot of depression and health IT stuff over the years. And Mike's trying to push this stuff forward in Michigan, predominantly in Jackson, Michigan. Okay, so overview. So I'm going to talk a little bit about what the problem is, why we're trying to deal with this. How did we get here? I think that's going to be fairly obvious to folks. We won't spend a lot of time on that. I want to put out sort of our view or vision for what hasn't been happening and what needs to happen in this space. We're going to have a little bit of vocabulary lesson about architecture and infrastructure, and we're going to show some pictures. And then we're going to talk about socio-technical design, and then we're going to get to this question that I've been asking ever since I got back from Newcastle last year. Is this just crazy talk? Or is there really something here? And I'm going to show you why I think there's really something here. And then I'll end with opportunities that are developing here in Colorado to push this work forward. So, it's always good to ground a family medicine talk by referring to Gail Stevens. So this was part of Gail's Family Medicine as Counterculture talk back in 1979. And Gail said at that time that the foundation of human reality is not mere protoplasm, the stuff that modern medicine knows so well. It's sentence and language and meaning and other beings that distinguish human reality. So it's not just about the lab results. There's more to it. Okay? So those of us that swim in the waters of family medicine, I think we kind of intuitively get this, but man, it's always good to see these words up in front and kind of ground us, and yeah, that's what this is all about. So, and I think you'll see as we go through this why I picked this particular quote out of Gail's talk. And it was given in Denver, so it must have been good. So the problem. So let's start with population stuff, okay? Obesity. There are a ton of consequences of obesity, and this probably doesn't even list all of them. I got this off the CDC website, but I think we could probably all add some things to this list. But obesity is a big deal. We've got folks in this department that are working hard on this problem and doing some really important work on it. But medicine alone is not going to be enough to solve this issue, either at an individual or a population level. This is a map that was made in the UK of all of the issues, factors, variables that they could get their hands on that play into obesity. Pretty complicated, okay? And this is just the physiology part. the part that we typically deal with in our practices and in healthcare. So there's food production. Are people getting access to the right kind of food? Food consumption, physical activity, the environment, psychology. Where's Ben? Yeah, so there's a lot going on here. Social psychology. So, and the good news is we're not in this fight alone, okay? So, if we say this is our bit, the physiology, maybe, we've got behavioral health that's engaged to help with that aspect. Rec centers they're in the business of helping people up their physical activity. Schools play a big part in kind of built environment stuff, places where folks can be physically active. Faith-based organizations, social stuff, for people who need to access food banks. Is the right kind of food there, or is it just high calorie, low nutritional value stuff? That's very important. And farmers markets, is there access to food that's healthy, that's gonna help people stay at a healthy weight? A lot of different pieces here. How well are these connected? Not very well. Not very well. Now, our colleague, Daniel Varda, down on the downtown campus, she's done a lot of work looking at different organizations in the community, how they interdigitate, and this is a paper that she was an author on that was in Health Affairs not too long ago. Health Affairs had an issue on culture of health, and this was one of the papers in that. So insights into collaborative networks of nonprofit, private, and public organizations to address these issues. So they identified 260 cross-sector community health networks, and these were groups that were using. They have a tool that they've built called Partner. It's a social network tool that sort of, you can go in, it's actually free to use. You can go in, you can set up your own network, and it'll push surveys out to people in your network and help you kind of analyze the connections. So they just took people that had been contributing data into that Partner tool. And so this is people from all over the country that were doing this, all focused on community or population health issues. Over 7,000, almost 8,000 organizations total. So what do they look like? I don't know how well you can see this, but so we've got the largest piece of the donut here up in the about 11 o'clock to 3 o'clock. Those are nonprofit organizations that couldn't sort of be identified in another category. So broad-based category there. Then we've got other local government agencies, schools, local health departments. Finally, when you get to about 6 o'clock there, you've got physician practices, colleges and universities, hospitals, that's about 8 o'clock, 9 o'clock, state health departments, other state government agencies, employers. Employers have a role to play here. Then we've got other and then faith-based organizations, community health centers, health insurers, and then finally federal agencies. So pretty diverse group of organizations. And this was basically the number of resources that any one organization contributed to its network. So you can see there's a pretty good distribution here, but kind of ranging anywhere from about 9 for state government agencies, up to about 12 for employers, other local government agencies, faith-based organizations contribute a lot of resources. So there's activity in this space. So when we go out and we try to look for partners, they're there. That's not a barrier. And yet, obesity rates are still going up. So all these groups working on these things, and we're still not quite making a dent here. So now let's take a different view. Let's go down to the individual level. And for this part, I'm not going to focus on obesity because individuals have more than one problem, right? So we're going to take an actual example. So this is one that came from Mike Klinkman up in Jackson. This is a patient that Mike in the Jackson area, which is just west of Ann Arbor, just so you can locate that geographically. Jackson has a pretty well-defined health catchment area around Jackson County. There's a little bit of leakage both to the west and the east, but pretty well-defined. They've got their own health system. They've had for a number of years a integrated set of physician practices, so they've had a community-wide EHR. So they're actually fairly well developed in terms of sharing information in their community. And yet, I think you'll see in this story that there were lots of gaps. So we're going to talk about Millie. Millie is a 72-year-old woman, pretty representative of the elderly population in Jackson County. She lives with her elderly husband a few miles from town, old farmhouse. They were a farm family, renting out the land now to others. She's got type 2 diabetes, peripheral vascular disease, neuropathy, congestive heart failure, coronary artery disease. She's been stented. Yes, she's got obesity, degenerative joint disease, and lots of issues going on there. Both are starting to be forgetful, have trouble managing their finances, but for basic stuff, they're kind of holding things together. So you sort of get the sense of this couple that are sort of teetering on the edge. Their income is Social Security. They get some money from renting out their land. Their son, who lives a couple hours away, manages the finances, sends a monthly allowance to his parents. They are rooted on their property, not willing to sell, don't want to move from their home because they'd lose the income from that, and they don't drive. So that's a problem. They've declined Meals on Wheels, rarely seek medical care because of their transportation issues, and they've missed a lot of medical appointments. So all of that was kind of known in the Jackson health record when Millie fell. Been unable to walk, more than a few steps, has a lot of hip pain. So this came to the attention of the care management folks in Jackson, and they had a care coordination meeting. Okay, good thing to do. So they knew about her medical problems, which we've talked about. They had pretty detailed clinical information. They knew that she wasn't walking well before this fall. They knew about the Meals on Wheels being declined. She'd been in the hospital. They knew about the missed medical appointments, all of that. They reached out to the Medicaid case manager, who knew some other things. Knew that, they really weren't interested in transportation. There were 3 ER visits for CHF exacerbations that somehow hadn't made it into the medical record. Nobody really knew the degree of functional limitation. Nobody knew about the consequences of this fall. the fact that they were starting to have memory issues, question of elder abuse, poor nutrition, and really how deep the financial problems were. So a lot of gaps. So Mike's team worked over about 90 days to try and fill in some of these gaps. And this is Mike's effort to kind of put together what it took in the absence of any kind of integrated care information to put this together. So they had to hand reconcile multiple medication lists. They were able to connect pretty well with the PCP because they have an embedded care management app within their next-gen EHR. They had to work out through phone calls and stuff to get her in for cognitive assessment, multiple other phone calls for referral to senior services, getting her in to see her patient-centered medical home, primary care. That took a lot of effort. Phone calls back and forth to the patient. A lot of telephone work. There was a home visit that had to be done. Lots of effort here. Whew. It's kind of overwhelming, right? So, the problem is, at a community or population level, healthcare can only provide a fraction of the solution. That hopefully should be obvious. Help exists in the community, but it's not connected. Information is siloed. And at the individual level, our healthcare and community resources, we're really kind of working in separate orbits. Everybody's working hard, but not really connected. And as a result, individuals and communities, we aren't able to provide the care that our communities and the people in those communities need. We all on the same page as the problem? All right. So, how do we begin to get out of this mess? Well, our view, and when I say our, I'm talking about myself and Nick and Mike and Jack's been involved in some of these conversations. So this is a little bit of manifesto here. So we believe it's no longer okay to keep this information siloed inside single organizations. Health and care record technology doesn't interoperate to serve the people rather than single institutions. We do a great job of keeping information within our health systems because that makes sense for our health systems. It serves their needs, but it doesn't serve individual or community needs. Clinicians and patients have not been at the center of design for these things. And we'll talk a little bit about what it would mean to put us at the center. There's really been no vision or leadership to say we need community-owned infrastructure to make this stuff happen. And we're calling for that. And we want to focus this on clinical interactions, clinical work, what's involved in providing care to individuals, and shared infrastructure to enable that. And we think there's a need for openness on data use with individuals. I don't know about those of you guys that see patients, but my patients tend to think this is already happening. What do you mean? You don't have that? I hear that all the time. Nope, I'm sorry, we don't. And finally, this is about creating a social contract that is about trust and about working together across boundaries to solve this issue. So that's the manifesto. And it's not that different from what's talked about in communities of solution. Okay, so this should look pretty familiar to people that are familiar with that concept that originated back in the Folsom report back in the 1960s, 1967. So maybe it's not a new view. Maybe it's an old view that time has finally come. But before we go any farther, I want to draw an important distinction. And that's between applications and infrastructure. Okay? So when you pull out your phone and you log in, all those little icons are applications, right? The apps that built specifically to do different things. So apps are developed to solve a particular problem. They're really good at specific tasks, dealing with specific types of data. They're bright and shiny. Okay? They're really attractive. And I mean that in that when groups that I've been talking to, both here in Colorado and other places, they're attractive to those groups that are trying to solve this. Well, we just need an application. That'll solve this. You know, if we had a care management application that incorporated social determinants of health, that would solve it. Well, I'm going to argue not so much. So applications, if you want to think metaphorically, think about cars. There's all different kinds of cars. Cars are fun to look at, sometimes fun to drive. But cars wouldn't be able to get anywhere without infrastructure, okay? So infrastructure is developed to enable lots of different solutions. So it's not specific to one type of app or one type of car. Provides support for multiple specific tasks, ones that we thought of today, ones that we haven't even thought of. Good infrastructure is flexible, can be used for a lot of different purposes. Problem is, infrastructure is kind of boring. I mean, you know, like we just want to know when we come in to the Krugman conference room that we can touch the screen and that thing's going to come down and you know, all that's going to work. That's infrastructure, okay? It's kind of ugly, but man, we really need it. And if you think about cars and roads, infrastructure is essential if you want to get somewhere safely. So think roads. So I'm talking about infrastructure here, not applications. That's important to understand. Okay. Architecture, infrastructure, and pictures, oh my. Now we're going to get really deep. Apologies to Mike Martin, because I'm using a lot of his slides here. All right. So, architecture. Who knows the roots of this word? Anybody? So, archi comes from a Greek root, which means before or prior to. Okay? And texture comes from techne, doing the technical stuff. So architecture is what you need before you can do technical stuff. Okay? So think about architectural drawings. For IT folks, we talk about reference architectures that show how data flows, those kinds of things. So they're the diagrams and text that help us talk to each other across different technical boundaries. So it's a communication tool. It's a way for us to say, here's a picture of what we want this thing to do, what we want this infrastructure to do. And what we're talking about is a reference architecture for community health information. Okay? So that we can draw this out, give it to some IT folks, and Kelly will make it work. Right, Kelly? And we're focusing on information to support care. So, what's that all about? Well, let's think about this. what kind of architecture needs do we have? So there's an engineering view or an engineering layer. And that's bits and terabytes, channels, bandwidth, the pipes that transmit data. You can measure that very precisely, okay? At any given time, there's X megabytes flowing across this. We're connected to this many different routers, networks. That's all very precise. But there's no meaning to it. We don't know what's going across that, okay, at that view. And the people that work at that level, they don't really care what the information is, right? The next level up is we call the informatics view, and that's where we begin to be able to say what the information is that's traversing. So we've got code, coding structures, ontologies, terms, objects. Can anybody say ICD-10? So just like ICD-10 codes, the meanings are pretty concrete. They're predefined, okay? Sucked into a jet engine initial encounter. It's actually an ICD-10 code. We move up to the top level, there's a socio-cultural view, which has to do with, okay, we've got this piece of information, but, you know, there's some value judgment here, there's some principles that we want to embody that define the intentions of how this information is going to be used. If I'm a hospitalist and I send a discharge summary to Jack Spittler, I've got an idea about what Jack's going to do with that, you know, hopefully. Jack's got an idea of what he wants in that discharge summary. What does he need to take over the care of that individual? And those have to be negotiated, okay? Now, in a lot of areas of medicine, within healthcare, that work's been done. We sort of know what a discharge summary is for. And there's some rules about that, but, you know, that had to be worked out over time. When we bridge over to community organizations, that work hasn't been done yet, okay? Well, what goes in this gap? That's about conversations, okay? So if you think of any transfer of information from one person to another, there's a conversation going on there, okay? That conversation means I've got a role, I'm a hospitalist, Jack has a role, he's a primary care doc. We each have responsibilities. Hopefully there's some relationship there. And that helps us to define the intentions of what we're going to do, what's going to be done with that information. So one way to think about this too is that if all of that stuff on the right side has been worked out, well defined, the concerns about privacy, information, because the intentions have been worked out, become a lot less, become a lot lower. So how does this actually work out if we take these concepts and map them onto a reference architecture? Okay, so engineering level. So we're talking about technical transport between two different points. We've got switching and routing signals. And we've got two different endpoints. We're delivering packets or packages of information between addresses, right? Point A to point B. Pretty basic. Well, what kind of information do we have that we're transmitting? So having a shared dictionary, codes, headings, data structures that define that information that's being shared. We have a document type. Again, this is a discharge summary. Now we move up to the top. And, what's going on here is we've got an originator and a recipient, a hospitalist and a primary care doc, and we've got this third party, the patient, right? Those have roles and responsibilities. We've got identifiers, and we can assign a purpose to the message. So this is very, very different from the notion of we're just going to hoover up all this information and put it up somewhere in the cloud. The difference here is we've got context. We understand because of the way the information is structured, because we've defined these things, what the context is. And that makes that information a lot more valuable and a lot more usable. Oh, I almost forgot. We've got governance. So we've got some folks that are overseeing this, making sure that the intentionality behind the transmission of that discharge summary is right between an acute hospital and a local practice. So who works this stuff out? Well, so we've got architects at each level, implementers, users. People actually do figure out policies on how the engineering stuff, there's standards. There's standards around the data structures, the codes, all of that. And I think those of us in clinical care are pretty familiar. There's standards around care pathways and that sort of a thing. But do these people talk to each other? Not very much. Not very much. Also something we'd like to change. So, again, here are our different views. Now, let's take this one step further. So, the acute hospital is sitting over there. Okay? That hospital wants to protect its information. It's required by federal law to protect its information. So we've got a firewall, baby. You can't get in. But we still need to communicate. We might need to communicate with a practice outside of the university health system. Okay, let's say this is a patient that's come in from outside, not from Jack, but from a practice elsewhere. So, whoops, let me go back to that. So we've got to have a way to get information across that firewall. And that's the work of groups like CoRio here in this part of the state, QHN. They work on that. But let's imagine that instead we've got a hub in between those two. Okay? This is start to introduce the idea of a community information hub. This hub just connects two different points. Okay? But there might be other systems connected to that hub. So in a hub and spoke model, all right? And that might federate up to CoRio, to a regional hub. And that regional hub might federate over to QHN on the western slope. So when Stephen goes visit his family in Grand Junction and shows up in the ER there, we have a way to get that information back here. But what is a hub and how does it work? Yeah, it's more than just a circle. So we already have things that function as hubs internally inside places like UC Health. That's how we make our integrated enterprise systems. That's how the lab system talks to Epic, all of that stuff. We know how to make that work inside an organization, but we want to take it outside because we want to go to middleware. So middleware is an important concept. It's an old one that came up back in the 1980s in business, okay? Because everybody was developing applications to solve certain things, and there was the notion that, well, these applications might need to talk to each other. So, well, let's develop middleware to allow these applications to talk to each other. So what are the basic functions of middleware? Well, you've got a portal function, and that's all about communicating with external applications. We've got that portal publishes information, syndicates it, can have search and discovery functions. We have to have an index because we have to be able to find where the information is, right? So we've got an index that keeps track of all that, understands what the relationships are between different if you think about identifiers, people, bits of data, what are the relationships there? And we've got a switch. The switching function makes sure that things get to the right place at the right time. So, in the index, we have to register identities. We might need to have in that, well, because somebody's a PCP, they've got a right to see a certain level of information. Somebody else might have different rights, all based on their roles. We have to know what the physical resources and what the different types of documents are. That's all indexing functions. So that's a hub, a middleware hub. And as I mentioned, hubs are good at connecting applications. So we're not throwing away applications, we need applications. So, and then the way that we pull all this information together is in a session. Okay? And a session, just think of it as you're opening up Epic or you're opening up your web browser, and Amazon probably does this as seamlessly as anybody else. Behind your Amazon screen are a whole bunch of different applications that are feeding information in. So they've got their inventory system. They've got a system that knows who you are, knows what you like to buy, and so it's going to present you with certain things. There's a whole host of things that look like it's just one application, but it's actually, you're seeing middleware in action when you sign on to Amazon. And so that middleware is pulling together information from all these different sources, all these different people, and presenting it in what looks like a unified layer. So if you begin to think about this with relationship to what we're talking about today and community health information, imagine that if when you opened up Epic, you could not only see the patient's visit history in A.F. Williams and their visits to the ED, you could see, oh gosh, they've been to the food bank. And, oh, they visited the housing office. Wonder what that's all about. And you could imagine, oh, yep, looks like they went to the rec center and they're starting to get engaged in physical activity. Good. You could see all of that when you open up a session in Epic. Transactions between hubs. So again, this is thinking about federation, and why this is so important is that, again, if you think about that top level where meanings and intentions are really social constructs, what we might decide is okay to share here in Denver, they might decide in Yuma, well, there's no way we're sharing that, because that's could be toxic. So communities need to define their own standards, but we can have connections between those hubs that allow us to share information based on what each community's decided is shareable. And federate identities and relationships. So if Stephen shows up in Grand Junction, goes to the ER there, the Grand Junction hub says, Stephen Cruz, we don't have him in our index. Let's go up to the QHN index. QHN doesn't have. Let's go over to CoRio. There he is. Stephen is in the Front Range index, and he's a patient at. So that hub functionality can be used to support federated communities of communities. All right, back to our reference architecture picture. So, discharge summaries, that's a document. We're creating that in a hospital session. It gets interpreted in a practice and maybe a community session. We've got this Federation hub, and that's linked to other community hubs. So now we've got not just a reference architecture for what's happening within our system, but how it connects outside. Now let's see what this looks like with a concrete patient example. Okay? So, this isn't Millie, this is Amy. Amy's a patient in Newcastle, okay? So Amy's fallen at home, and she had a medical alert bracelet, so she was able to get the paramedics to come, and she shows up in accident and emergency. So the ED, in the acute trust hospital. And because they're up to date in Newcastle, they get lots of consultants on board. They get the geriatrics person, they get the orthopedist. She has x-rays, oh my gosh, she's got a broken hip. Pathology, they get urine from her, oh my gosh, she's got a UTI. Maybe that's why she fell. Well, we better fix her hip. We take her to the OR, and we've got nursing, all of these different folks within that acute hospital are contributing different pieces of information, different documents into their internal system. Now, oh my gosh, Millie seems a little forgetful, a little maybe depressed. Let's bring in a psychiatrist. Boy, we should probably think about getting social work involved because she's living at home. We need PT and we need OT, so those folks get involved. Now it comes time for discharge. So we have a discharging doc that's getting information from the gerontologist, the orthopedist, and sending a discharge summary over to the GP. And practice nurse in the UK, they've got practice nurses that interact with the community. The practice nurse gets a community nurse involved, community psychiatric nurse, social worker, occupational therapist, and a physiotherapist. All that happens now, okay? But all those people, just like here, even in the UK, they have different systems. They're no better than us when it comes to information sharing. So, let's create a drawing that shows how all those sessions might interact. And the last piece is the coolest. That's where Amy and her caregiver can sign on to a session and see all of her information and what's going on with her care. So this is dynamic, and the underlying documents come together to represent the narrative record. So we still need to make sure that we've got governance that answers the questions. Is the information that's going across these lines, is that what we intended? Do we still intend this? Governance has to be ongoing, active. Really the place that we start and the place that we never end is with governance. And that's our middleware picture. So how do we get started with this stuff? If we want to do this in Longmont, we want to do it some other place, how would we get started? Well, this is where socio-technical design comes in. So socio-technical infrastructure, let's imagine for a moment that you have to make a telephone call. And you're calling somebody that you've never met before, but you need to do some kind of business with them. So somehow you've got to introduce yourself, you've got to say why you're calling, and if you're going to do business with this person, you got to establish a little bit of trust, right? So there's some stuff that we just naturally do. We've learned this from an early age. Gosh, when you're calling somebody, here's how you should introduce yourself, blah, 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 blah. We all learn that. It's kind of gets wired in. But we never think about that when it comes to information transfer in IT. But the same principles apply. Imagine that you have the same telephone call with somebody that you know and you've worked with before. What's different? Well, all that stuff's been negotiated, right? So again, back to the example of I'm discharging somebody, sending a discharge summary to Jack. That's been worked out. First time we might have had to have a conversation, but now we know what's going on. So can we imagine health data exchange as this kind of conversation? So again, it's not just dumping information. We don't know what's going to happen to it. We don't know what purpose it's going to be used for. But we actually have a conversation about why am I sending you this information? What do I want you to do with it? And what do I need back? That's socio-technical design. So socio, convening the parties responsible for all these different pieces of care and health, defining those roles, what our duties are, our relationships together. So again, if you think back to our reference architecture picture and our relatively simplistic example of a discharge summary, that's what you do. And the technical part is then taking those kinds of requirements, those kinds of definitions, using the reference architecture and building all of that stuff that supports it. So that's how we get patients, clinicians, people in the community service organizations all together to have a conversation about how this should happen. Complicated. So is this just crazy talk? Maybe. Well, this is what gives me hope. We've got some working examples. So in the UK, they have a $5 million project to start putting this on the ground in the northeast of England. Their three main objectives are to join up frontline care information. They're developing a common analytics platform. There are 5 universities that are involved in this. They've got social care involved. And they're working on developing this social contract with people and patients in the northeast of England. This is a big deal. The fact that Nick Booth even has time to talk to me is pretty impressive, given what they've taken on. And these are some of the systems and standards folks that have signed on to work on this. We actually have a working example in our backyard, too. It's not around health, but it's around the public schools. So Civic Canopy is a local organization that they've used a socio-technical design process with the Denver Public Schools to connect up 400 different organizations with roles in youth development, after-school programs, all that are all going to be sharing information about students. And, we've got HIPAA, they've got FERPA. They have worked this stuff out. So there's a pretty cool example there, and they're actually interested in working with us to bring health and care into that. There are standards organizations that have defined standards to make this stuff work. So we don't have to invent things. It's already on the shelf. So what are the opportunities? We're just about done here. So as Mike Martin says, we're forming a coalition of the wise and willing. So Mark Lasso is the Chief Information Officer at QHN on the Western Slope. Mark's been involved in these conversations. Patrick Gordon from Rocky has been involved. Lauren Ambrozic from the Colorado Prevention Alliance, which is the payer collaborative. Bruno Sobral. Bruno heads up the One Health Institute at Colorado State. Bill Fulton from Civic Canopy. And we've got our UK partners, Nick and Mike. And on the Michigan side, Mike Klinkman and Matt Pletcher runs the Michigan Health Information Network. We've been convening people. So we, right after NAPCRAG, 4 of us piled in a car and drove to Durango and presented to the Western Colorado Accountable Health Communities. Right after that, we took advantage of Nick and Mike being here for NAPCRAG. We had a convening here in the Denver metro area. We had about 55 folks, including people from CDPHE, HICPUF, a lot of different organizations. There's a lot of interest in this. Interestingly enough, we have a couple of community opportunities. So Longmont, the guy who's come in to head up the new hospital in Longmont reached out to me and said, Don, can you come up and talk about community engagement stuff? Wearing my CCTSI community engagement hat. So sure enough, I showed up and we had a meeting with the city manager, the fire marshal, and the chief of public safety. And it was kind of a, well, what are you guys working on? What are you interested in? And I told them what we did. And pretty quickly they started talking about, well, you know, we're trying to get our arms around 3 different big issues here in Longmont. And we've got this community network that has started meeting about this stuff, but we need some tools. We need a way to connect this stuff up. Oh, okay. So we're continuing to talk. CSU, Colorado State Engagement, they're opening a new engagement site. Their first one was up in Sterling. Their second one's going to be in Castle Rock, and they're interested in trying to do help facilitate some of this work in Castle Rock. There's opportunities there. So back to Kel Stevens. We're not just protoplasm. We're sentence, language, and meaning, and other being. That's what distinguishes human reality. And only by embodying those things in the systems that serve care and health are we going to move this stuff forward. That's all I got. Question? Yeah, Kelsey.
Tell me more about how the government will be created. Will it be kind of like organic initiatives like the Mama?
So Kelly asked about how will we create the governance in different communities? And I don't have a pat answer. I think it probably will be organic. It's going to, where communities have existing networks that are functioning, we'll probably piggyback on those. And I think what I'm looking for are places where there are those existing networks. Because to go in cold and try to start these conversations, I think will be difficult, but I think it's a place where I've talked to Perry about our regional health connectors being important resources to help facilitate that in communities. So I think we've got those folks, our community research liaisons, where we have those people deployed, I think can help with that. But yeah, I think it's probably going to be a little bit different in each community. Yeah. Yeah. Yeah, so that's part of it. So the question was, if you're Amy or Amy's daughter or caregiver, and you're pulling up Amy's page, that's that session that sort of is designed to summarize all of her information. How do you avoid redundancies? How do you avoid duplications in that information? That's part of what the middleware hub will do, is so because of the way it's designed, the rules that are embodied in that, it has a sorting and a filtering function, so that, and that may be different in different communities. But, you could imagine that it's going to be set up so that initially what you're presented with is a summary level from the different sectors of care that are involved with Amy. And then you've got a way to dive in to different pieces. Or community might say, well, we want somebody to see when they sign in the most recent information. And then if they want, they can navigate up to a summary. So it could be different in different places. Linda and then Brian. Right. Yeah, so that Linda's question really gets at trust, and are patients really going to be comfortable with these things being shared? And that's where I think it's really, really important that we involve groups like patient advisory councils, and we get those folks at the table, and that our governance structure isn't just the CIOs and those folks, but it's actually got free-range humans that are involved that can help us make sure that again the intention match what's actually happening, what's actually being shared, and that's the only way that you can start to build that trust with folks. Brian, and then Frank's reaching for the bell.
So I wanted to just comment on the idea of having this for this assessment that helps maybe together in relation with some of the things that are going on. Particularly with regard to our model evolving state of healthcare and so forth. Does this happen as a result of that? Does this happen in tandem with that? Does this happen despite that?
Yeah, boy, that's a good question. So Brian's asking about how all this stuff relates to payment models and how care is reimbursed, paid for. That's a really big and really important question, which I don't have an answer for. But what I do think is that at a community level, I think we've talked about how valuable this information might be at the point of care. We've talked about how valuable it might be at an individual level. What we haven't talked about is how this information could be used to help understand the needs of a community and where gaps exist, those kinds of things. And at that level, I think it could be helpful in terms of understanding how payment structures might be better optimized to plug those gaps and to support where things aren't happening or where maybe care is happening unnecessarily. So that's about as far as I can go with that, but that's a good one to chew on. Yeah, thanks for that. All right.